So welcome, everybody. Before I introduce the program, I just want to say that this is oh, Elizabeth is here. I see. Oh, but you have your mask on. Okay. So Dr. Alkalay, you see, Elizabeth's here. Elizabeth's here, so she's with us.
I know. Sure.
Okay, good. I want to just welcome everybody as they're coming into our meeting. Remember that you can change your name to protect the innocent. You can turn off your camera, whatever you wish, or we would love to see you. So, because this is a meeting, it's not a webinar. Also, if you would like to ask questions, I'm happy to have you ask them yourself. So you just turn on your mic, or you can write it in the chat and I'll ask the question for you. We are going to take questions in the middle of Dr. Alkalay's talk and at the end, and you'll be able to address questions to both Taryn and Dr. Alkalay. Remember, we're going to keep our questions to the topic, and then if you have any personal questions relating to your own personal treatments and diagnostic situation, please ask your own doctor. I want to introduce myself. I'm Susan Lust, and I'm co-director of the Parkinson's Wellness Project. Our mission is to bring education, awareness, and social interaction to people with Parkinson's and their families. We also have workout classes, and I just came from a boxing class this morning, so I'm very energized, and I really got inspired by our class today, because not only is it a great workout, but my brain was between the cross, the hook, the punch, the this, that, my brain was going cuckoo. So our classes are for everybody. We're geared towards people with Parkinson's, but we want you to come with your friends also and your family. So we're opening it up to everybody. Evelyn, we missed you this morning, but okay. So what I'd like to introduce, this is our PWPMD Lunch with Our Doctor. And this is our 5th in the series. And this month we've done one already. We have today and one more, and we're working on prevention in PD. Knowledge is power. And learning from our talented doctors is a great opportunity. And we are fortunate to bring these programs to you because our sponsors understand that empowering our community with education is so valuable. So we'd like to thank our sponsors, Acadia and Kaiwo Kirin, for supporting the work that we do. And they know that power of knowledge is important. So thank you very much. Now, I'd like to introduce Dr. Roy Alkalay, who is joining us today. He just waved in the blue shirt there. He is the Alfred and Minnie Bressler Associate Professor of Neurology and a member of the Movement Disorders Division at Columbia University Irving Medical Center. He recently moved to Israel, where he chairs the Movement Disorder Center at Tel Aviv Sourasky Medical Center. He obtained his medical degree from Tel Aviv University and his neurology training from the Harvard University residency program at Mass General. And his movement disorders training was at Columbia University. Dr. Alkalay earned a master's biostatistics, which is patient-oriented research, from Columbia University, and his research focuses on biomarkers and genetics in Parkinson's disease. And today he will be talking about genetics of PD, converting risk to hope. But we will hear from him shortly after we have a little chat with Taryn. And Taryn is joining us from Johannesburg, South Africa. She's a wealth of information, and I'm so happy to have met her. She is a functional medicine certified nutritionist and health coach. And she looks at the whole person, not as a series of symptoms that have to be treated. She focuses on nutrition, good eating practices, exercise and mental health. And
Yes, will you be able to send me?
Yeah, keep your sound down. Anybody who's not muted, please mute. And she is joining us today from Johannesburg. Thankfully, the internet is working over there, and she can be with us because it goes on and off all the time. And she will be talking to us today on reducing symptoms through nutrition, connecting us to our topic today, genetics. So please welcome Taryn.
Hi, everybody. It's wonderful to see you guys again. I've sort of latched onto Roy's talk about genetics today, and I wanted to just discuss with you how your eating and stress and your illnesses and your environment have an impact on your genes. And as I said earlier with Dr. Alkalay, is that we can't change the sequence of our DNA, but what we can do is how our environment and our eating habits and things can have an effect on the way the genes work. And I'm just going to use myself as an example here. It's probably the easiest way for me to explain this is looking at my family history of our genetics in our family is quite scary. My mom died 26 years ago at a very young age of obesity and diabetes. She had high blood pressure. She was a smoker. My dad recently died of cancer, high blood pressure, cholesterol. My brother is morbidly obese. He's got diabetes. He's got high blood pressure. My sister's on warfarin. She's overweight. My grand died of a brain hemorrhage. It's the blood clotting has come into effect. I've got these genes. I've got the obesity gene. I've got the MTHFR gene. I've got the cholesterol gene. I've got the insulin, the oxidative, the oxidative stress, all of that. But yet none of them have, I'm nearly 60 now, and none of them have actually really shown any reason to be, I'm not on cholesterol tablets, I'm not diabetic, I'm not overweight. And I've worked very hard over the last 30 years to actually change the way I've seen what's happened with my family. So I've done everything I can to make sure that I do not end up like that, because there's a very big chance that if I had eaten and carried on eating the way that I was brought up, I would be in that same situation. And so the only thing that has changed of what I've done over the last many years is actually changed my nutrition. I'm not great on supplements. I don't take a million supplements. What I do is I work my diet. I work everything that I put into my mouth. I make it as a conscious decision to make sure that I do not end up where they are. And so where we are today, it is about you, but it's also about your family, about the future, about your daughters and your sons, also to make sure that they don't end up with same sort of illnesses, diseases, cholesterols, diabetes that you've got. So what you eat during your pregnancy will have an impact on the way that your kids, they are, what's the word, they come out and how they grow up. And that's what I've seen in my family. And so one of the biggest problems that we do have in our family is blood clotting. And so again, what I do is I work my diet to assist with that as well, to make sure that I exercise enough, that I get in the right nutrients. And again, it comes from food. And I know for many of you, because we've been in this a couple of weeks now, I'm a great believer in what I call my superpower green smoothie, because that's what I use to make sure that I get all my nutrients in. And so Susan was actually saying to me this evening that, Americans like everything a lot sweeter than possibly we do. And I did notice that when I was in the States, is how everything is just sugared and sweetened and laden with my goodness, there was nothing without sugar in it. And I also found that it was quite difficult to get fresh produce. And so Susan said, maybe we should add more sweetness into the smoothie, and I should be explaining to you more about my green smoothie. But the big thing is that I see there's a question about the green smoothie is available. I think that it is actually on the website, but I can always give it to you guys. But the big thing is we want to get in as many greens as we possibly can. Also, with the fact that a lot of you are on medication where it interacts with protein, is we can always use our green smoothie to put a lot of nutrients in during the day, rather than you snacking on cookies and just trying to get through the day. And I've actually spoken to quite a few of you, and your diets sort of interact between taking in cookies and having a piece of fruit and really not eating enough during the day and not sustaining yourself, but not only that, it's getting enough nutrition in. And so the green smoothie is one place that we can put in as many leafy greens as we possibly can get in. And you add in your apple delight for that little bit of sweetness. And of course, it's got all those incredible herbs that you could be putting in. And I'm not going to go into a lot of detail about what each vegetable can do for you, but it can clean out your system. It can help, they're antibacterial, antiviral, especially a lot of these herbs. You've got your beetroot that we were discussing last week to get your tummy working if you're suffering from constipation. You know, those are also high in folate. And that was one of the things I wanted to mention. There is being a lot of, and I'm sure that doctor would actually mention something, I don't know if he will, about the MTHFR gene, but that gene, for example, requires folate or 5-methylfolate. And you can also get a lot of that in your green vegetables. So your asparagus and your lettuces and your cabbages and your beetroots and things have high levels of folate in it. And you could, which is your B9. And so throw in as many things as you possibly can. And I've mentioned here the benefits of taking in folate. It can help to lower your homocysteine levels. And again, one of the things that I found when I did blood testing many, many years ago, when I decided to change my eating pattern, was my homocysteine was high. And not a great believer in taking a lot of tablets. I decided again, how can I work my homocysteine level to bring it down? And so my homocysteine now has come down from 11 down to 6. And that is just with my nutrition. So taking in folate is reduces the risk of Alzheimer's and Parkinson's, prevents birth defects, promotes health, heart health, helps break down triglycerides, decreases the risk of colon cancer. Again, I've written at the bottom there is you find it in turnips and leafy greens and asparagus and legumes and beetroots and avos. And these are the kind of things that you could actually be eating during the day. And these tastes may not be, they may be a bit foreign to you if you're not used to eating a lot of these things, but they generally, when you take them in raw, are actually very neutral. So quite easily to put into a green smoothie. And I know Susan is hooked on to green smoothies now, and she drinks a lot of them, but you can see incredible changes with this. And one of the other things that will sustain your blood sugar levels throughout the day when you are not using protein, because one of the great ways to stabilize blood sugar levels is actually with proteins and good fats. But we can't do that if a lot of you are on levodopa and things like that. So this is one way that we can put an incredible amount of nutrition into one glass. And if you could just have 2 glasses of my superpower green smoothie in a day, you are doing 100 times better than you were doing before. And adding in a little bit of avocado to get in a tiny bit of fat would be absolutely incredible. Here is the smoothie that's on the screen now, is the beetroot smoothie that I was talking about last week, because beetroot acts as an incredible laxative and can also get your tummy working and supply you with high levels of calcium and folate and potassium and vitamin A, and of course all that great dietary fiber. So add that into your diet, put in my Apple Delight and blitz it up. Try it. Never say no to something. Always try it 3 times. I always tell my son this, try it 3 times. And if you don't like it, well, we can talk about it after that, but give it 3 chances. And by then I'm sure that you will realize that how good it is for you. It may not be what you want, but it is what you need. So if I can put it that way. Susan, over to you. Your sound is off.
Oh. Sorry about that. That was like a baseball game, 3 strikes. And it sounded like a song. You can't always get what you want, but you get what you need.
Yeah, you get what you need, yeah.
Oh, thank you, Taryn. I hope that was a good appetizer for our main course, Dr. Roy Alkalay. So thank you for being with us, Dr. Alkalay. And I just want to say before he starts that Elizabeth Delaney is here with us from Columbia Presbyterian. Just give us a wave. And she's a wealth of information. She's at the PD, what is it called? The Parkinson's Foundation Excellence. What is it?
The Center of Excellence at Columbia
Center.
Medical Center. Yeah.
Right, the Center of Excellence at Columbia. So everybody should be connected to Elizabeth and all the great work that they do there. So Dr. Alkalay, thank you. I was hesitant to have this subject, but you convinced me that this is very important for all of us to learn. So welcome.
Thank you for inviting me, and thank you for spending lunch with me today. Yeah, well, in my case, it's dinner. And so I wanted to talk about the genetics of Parkinson's, and using the title Converting Risk to Hope, I will start with talking about what the genetics are, which would be the risk, and then we'll take a pause for questions and talk a little bit about the hope. So I am known to be a person of facts and a lot of data. So I'll do my best not to overwhelm you. And please use either the chat function or the break to ask me questions. I'll also say that in addition to me, Evelyn from my team is also here, Evelyn McKenzie, and she's waving at you. And you can also reach out to her, and after we're done, you can absolutely reach out to her. So people develop Parkinson's disease. Why do they develop Parkinson's disease? It's a question that if you struggle with Parkinson's, you must ask it. The question is like, why me, or why my loved one, why my family member? And it's a question that beyond the maybe emotional, maybe religious, maybe questions of it, there's a true scientific question. Why did one develop Parkinson's? We want to know it to prevent it in the future. We want to know it to understand why does it happen and how. And the bottom line is that in the big question of do we know what's the cause of Parkinson's, we don't know yet. We, in contrast, know what are the causes of Parkinson's. We found a few risk factors that if you have them, your Parkinson's risk significantly increases, but none of them is, or very few of them are sufficient to cause Parkinson's on their own. So, for example, being like not eating healthy is a risk factor for obesity, but there are people who don't eat healthy, like my daughter who eats very bad food, but she's skinny. So there are, so it isn't just one-on-one. It's not like, okay, if you jump off the 30th floor, you're likely to crush your vertebrae, which in that case, really, it'll be 100%. In Parkinson's, the risks that people are exposed to don't 100% cause Parkinson's. They're primarily what we call risk factors. And in general, we can divide the risk factors in the world to genetic, environmental, or interaction between genetic and environmental. So almost everything we think of, everything that we're exposed to, everything we know is caused by either genetic, environmental, or the interaction between them. So if I'll take something that is more of current affairs, like the COVID pandemic, sure, developing COVID is something environmental. You need to be exposed to a virus in order to have COVID. No one who is not exposed to the virus will have COVID, but how would your body respond to it? That's a much more complex reaction. There are some environmental factors that will make people's response milder. For example, younger age, for example, being given the vaccine before. But there are also probably, and people are studying it, also genetic risk factors that make some people more susceptible for bad COVID and some people to be more protected. And we do know that there are people with no risk factors like young age that have had very serious outcomes with COVID. So even a disease that is completely like you would think about it as completely environmental, it's a virus and exposure, has a genetic component to it. So the problem is that if you have one action, one reaction, it's very easy for scientists to learn. If you eat bad food and you go and have a stomach upset and throw up, you'll immediately make the connection and you won't eat that food anymore. We learn to do that. But if the risks happen years before you develop the disease, and just some of the people exposed develop the disease and others don't, then it's much harder to find the link. So let's say that drinking, like being breastfed compared to formula, increases your risk for Parkinson's. It's something that will be very, very difficult for us to discover because Parkinson's happens around 60 years after the exposure. So the longer the lag between the exposure to the disease and the lower the rate of people who are exposed that develop the disease, the harder it is for us to find the links. Having said that, we have done multiple, there's been multiple discoveries in the field of Parkinson's. And it started in the very late 90s when the first genes linked to Parkinson's have been discovered. Now, this now goes without saying that there are some genes that cause Parkinson's, but at the time it was revolutionary because in neurology textbooks, Parkinson's was called a non-genetic condition. Now we realize that there are genetic risk factors we discovered and genetic risk factors we have not discovered yet. The genes discovering the genes, and that will be a little bit the second part of my talk, shouldn't discourage you with saying, oh, I was doomed to develop Parkinson's, or my loved one was doomed to develop Parkinson's when they were born because it's in their genes. Because just as you heard from the last talk, there is a lot that one can do even when the genetic exposure is there and the genetic risk factors are there. So in the beginning, the genes that were found are genes that, or mutations in the genes that if you have them, your risk for Parkinson's is very high. So there are very rare cases of families where you look at transmission of Parkinson's from parents to children in a way that anyone that has the gene has the disease. And these are genes that are very rarely found, mutations that are very rarely found in cohorts of people with Parkinson's, specifically in two genes, alpha-synuclein, which that gene is in charge of the protein that is deposited in the brains of people with Parkinson's. If someone donates their brain to Parkinson's research and we look under the microscope, we see alpha-synuclein. And another gene that causes Parkinson's in people who develop Parkinson's in their 20s or 30s, and that gene is called Parkin. And if you develop Parkinson's in your 20s, the risk of carrying Parkin mutations is very high. But as you know, very few people develop Parkinson's in their 20s. So then over a decade passed with not a lot of discoveries until two new genes have been found. One of them is called LRRK2, LRRK2, and the other is called the other one is called GBA, or glucocerebrosidase in its longer name. They both have a couple of similarities. One is that most people who carry mutations in these genes will never develop Parkinson's. So it's a major risk factor, but still the majority of those who are exposed to it don't develop the disease. In LRRK2, 1/3 of the people who carry mutations develop Parkinson's, and in GBA, it's maybe 10%. So still, if you have a mutation, 90% that you'll never develop Parkinson's. This number, it depends if you're an optimist or a pessimist. When you say 10%, it's not that high compared to 90% that won't develop it. But of course, 10% is much higher than the general population risk for Parkinson's, which is roughly 2%. Okay, so it increases your risk by 5-fold if you want to stress out. If you want to be less stressed, you can say the risk is only 10%. And the other thing that is in common for these two genes is that mutations in them are more likely to be found or more common in people of Ashkenazi Jewish ancestry. So nowadays, in cohorts in Israel and in New York and all over the world of people of Jewish ancestry, roughly 1/3 carries a mutation in the gene, either GBA or LARC2. So these are the two similarities: higher frequency in the Jewish population and what we call incomplete penetrance. If you have the gene, you don't necessarily have the disease, but your risk is increased. Where the two genes differ is that the Parkinson's, the cause is a little bit different. People with LARC2 may have a longer progression, longer disease duration, with very little cognitive changes, sometimes none. If they have cognitive changes, you need to find another cause, like aging or something else. And if they were kind enough to donate their brain to research when they pass away, not all of them have the Parkinson's changes in the brain. So they have Parkinson's symptoms, but not Parkinson's when you look under the microscope. The people with the other gene, with GBA, have a typical course of Parkinson's. It can be maybe even a little bit faster than the typical Parkinson's, with more rapid progression, but still they respond very well to the Parkinson's medications. So with this data, the next thing that people asked is, do people with Parkinson's want to know if they're carriers or not? So the second part of the talk, after the break, I will talk about the hope and about why people may want to know. But I will just say that besides that, the reason some people want to know is, some people want to know that if they're still in family planning age, and they would like to know, and they would like to see what kind of technology can medicine help them with family planning. Another reason people want to know is because some people just are struggling with Parkinson's and they want to know why they developed the disease. And that's a fair feeling that many people have. And the third reason why some people want to know is that they would like to know what's their prognosis, because we know that these genes can impact the rate of progression. So if people want to know, I want to know if I'm likely to progress slower or faster, the genes can help us with that. But really, the most important question when you think about the genes is, what do I do with the data? Is there anything that I can do? And the short answer is yes and no. And I'll describe, no, there's no FDA approved intervention. Yes, there's lots that you can do if you find out that you're a carrier, which I'll describe after the break. But just before I go in, I want to say, like, when people get genetically tested, the implications are not just for them. There's a whole family involved. If you carry a mutation in the GBA or LARC2 gene, it means that anyone who's the first degree relative, which means your parents, your siblings, or your children, all of them have 50% chance of carrying that gene, that mutation in the gene. And people may choose to tell their family, they may choose not to tell their family, but getting a positive result may impact them. It may impact them in a positive way, where they can then get tested and find out they don't have the gene, so then they don't have the risk that they were concerned about. It may affect them in a way that it will make them more stressed about the risk of developing Parkinson's because it runs in the family. So the other thing is that we discovered, and that is in Parkinson's, we're always lagging behind cancer. Why are we lagging behind cancer? Because the cancer doctors have the advantage that if they find a tumor, they tell the patients, hey, let's take it out. They take it out, they look under the microscope, they can dissect it in the lab, they can learn a lot about it. If I told my Parkinson's patients that they have Parkinson's, let's take a little piece of your brain out and I look at it under the microscope and learn about it, the right thing to do would be to fire me. So, of course, we are lagging behind the cancer world because they can look at the cancer and then they can say, oh, I see this or that, let's give this drug. And then they give that drug and then they say, oh, the tumor is still there, let's look at it again. And they do another surgery to remove it. We don't do that in neurology. In Parkinson's, in Alzheimer's, in seizures, we don't do that. It's very rare we take a look at the tissue under the microscope until it's way too late. So, of course, we'll always be behind cancer. But we have to look at the cancer world to see what kind of therapies they developed and apply them to us. And the two types of therapies that the cancer world developed that we're applying now to neurology, to Parkinson's, is one is to activate the immune system against the tumor, against the cancer. In our case, is to see whether we can activate the immune system against Parkinson's. And the second thing would be to see whether we can stop treating Parkinson's cancer as one disease and treat it by the genetics. And that's exactly what we're doing with looking into the genes. So in lung cancer or glioblastoma, brain cancer, you can take a panel of genetics from the tumor itself, and based on this, tell people their prognosis and also what kind of treatments they need. The response to treatment depends on the genetics of the tumor. We're pretty much convinced it's going to be the same in Parkinson's. We're just not there yet in many ways. So that's what we're working on to get there. So this was me in very briefly talking about the risks. And I want to open it up for questions so it won't be too heavy before I talk about the hope. So that's a good time to ask questions either by chat function or just ask me.
Right. So if anybody has a question that they want to speak themselves, you can turn on your mic and ask it, or you can write it in the chat. The first question we have here is, if I do have the gene, what is the risk for Parkinson's for my children?
So that's a very typical question to ask, is if I have the gene, what's the risk for my kid? So first of all, I want to remind you that if you have the gene, if you have the gene, the risk for your child or just any first degree family member is 50% that they carry the gene. But if you remember, we said that the gene itself, the mutation in the gene doesn't mean that you'll develop Parkinson's. It's just a risk. So you need to do the math. If you carry the LRRK2 gene that gives 30% risk for Parkinson's, and your child has 50% chance of carrying that mutation, so the kid's risk is 15%. Okay, so the risk for the kid is elevated, but it's still not overwhelming. I think that if you ask the children, they often overestimate the risk. They said, oh, my parent had Parkinson's, I'm likely to have Parkinson's. And that's actually not the math.
Okay. If I do not have the genes, what is the risk for Parkinson's for my children if I don't have the genes?
Yeah. So the risk for Parkinson's in kids of people with Parkinson's is elevated, and it is what it is. In people who have the gene, we can find out why it's elevated and tell those who want to know whether they got the risk or not. In people that, like, if one with Parkinson's get tested negative, there's no point to test their kids, because if they have genetic risk factors, we just didn't find them yet. The fact that we now know 7 or so genes that cause Parkinson's doesn't mean that there's not many more that we just didn't discover yet. That's why the research is ongoing. So the risk for a kid of a person with Parkinson's is roughly 7% or so, which is triple when compared to the general population, but it's still quite low when compared to the risk of not having it.
Mm-hmm. What about if your brother has it and then you have it and then your children have it? Like it's somebody else in your family. That's
right. So if the fact that your brother has it doesn't affect your kids, because it's, again, you roll a dice, 50-50 that your kids got the gene. So, but if you don't know that you carry a gene, then the more people in the family that have Parkinson's, the more likely that there is a gene hiding there that we may or may not find.
Mm-hmm. What's involved with testing for the gene? What is that test like?
Okay, so that's an easy question to answer. So for a very long while, it was a little tricky to get tested for the genetics for Parkinson's, because different labs offer different panels, and some panels are too big and some panels are too small. And in order to overcome the challenge of access to genetic testing, the Parkinson's Foundation funded the PD generation study. And for this, even from your own homes, you can participate in the study by hitting up on Evelyn McKenzie, Evie here from my team. She's the research coordinator on the grant. And they recruit you by telemedicine, or in person, whatever you prefer. It's at no cost. They offer genetic counseling before getting tested. which is very standardized with a video. You either do a blood draw if you come to Colombia, or a buccal swab to get it from your saliva if you do it by Zoom. And you ship it by FedEx. And 6 weeks later, we schedule a telemedicine visit, or a Zoom visit, to give you the results back. So
And-
pretty easy at no cost.
So do they have that visit with you or with somebody else at the center?
The first visit will be with Evelyn or another coordinator in our center, and then the genetic results back will be either with me or with other clinicians from the center, Lynn Cadis or Julian Egan-Labis.
Okay, all right, so we have a question here. Okay, so knowing that you have the gene and which one, you mentioned it does affect the treatment. How can you talk about that?
Okay, so yeah, let me talk. I will say what more it can do, and I'll talk about the hope in a minute. But I will say that people are looking into what kind of treatment, if the treatment should be affected by the genes. Currently, there's nothing that is formed that is under consensus of all doctors. But it looks like the effect of deep brain stimulation of the surgery may be different in LRRK2 or GBA. So before getting the deep brain stimulation, for those of you who may be interested, I encourage you to consider genetic testing. People with LRRK2 generally do well, so that can be encouraging for people who want to do DBS. People with GBA can do well, but they can also have some cognitive changes. So that's something that may dissuade people from doing the deep brain stimulation. But there's active research on it as we speak, trying to sort this out.
Okay, there is a question here. This is interesting. If the two siblings get tested and they don't have the genes, does that mean that there's something obviously that we don't know about yet? I mean,
right. So we need to be humble. There's lots we don't know about. Now, it is possible that these two kids used to grow up in a farm and someone sprayed them with pesticides since they were kids, and even though they're kids and you see siblings and we think about it as environmental, as genetic, the risk is really environmental. On the other hand, it's very clear that there's a lot more genes that we haven't discovered yet. And we are working on it, and the people that participate in PD generation will get the results back for the genes we already know, but they will also be asked to allow us to use their DNA to keep on looking for additional genes. So, and those who participated, they should know that they keep helping Parkinson's research, because their sample is a gift that keeps giving, because we will discover more genes. It's just a matter of time.
Interesting. Well, that's nice to know. This question over here, monoclonal infusion study, is that something that you're talking about? Is that?
So I'll just mention it in one word, because I did mention it. So I told you that if you asked me what's most exciting happening nowadays in Parkinson's, I would say that it's the inflammation and the activating the immune system and the genetics. So the monoclonal antibodies infusion that people are talking about are basically antibodies against this protein alpha-synuclein, activating the immune system to say, we don't care if the immune system is really involved in Parkinson's or not, let's activate it to get rid of the Parkinson's changes in the brain. And that's that infusion study. We ran two of them at Columbia, one by Biogen, one by Roche. The one by Biogen was stopped for no effect. The one by Roche is still going.
Okay, very good. Let's see.
So then there's another question about, so let me continue, because I think we took a sufficient break, and then we'll see that I'll take more time for more questions.
Terrific.
So now we heard that there are risks with the genetics. What's the benefit in knowing that you're a carrier? We talked about the fact that people just want to know. We talked about the effect on the prognosis. We talked about people who still are in family planning stages and they want to know their risks. Israel is actually much more liberal about it than the United States. They do all those like fancy IVFs to try to prevent Parkinson's in future generations. Ethically tricky, but not go there. But the real reason, the game changer, the reason why I think that the talk is important today is because we're talking about the future. And the future is that not everybody takes more and more dopamine, and what we do is do dopamine and then more dopamine and then even more dopamine, but try to tailor the treatment to the people's genetic makeup. And for that, there are clinical trials around the world targeting the LRRK2 gene for people with LRRK2 mutations. There are treatments around the world targeting the GBA gene for people with GBA mutations. Now, for people who are inclined to participate in research in clinical trials, you won't be able to participate if you don't know that you have the mutation. So that is why I think it's such an important effort, not to encourage people to get genetically tested, but to make it accessible for those who are interested. Because when there's sufficient people who know that they're carriers and are willing to participate in trials, these trials may mature to a new treatment for Parkinson's. So remember, when we do clinical trials, maybe the corona vaccine is a little bit different because they were all successful. But when we look at clinical trials for other conditions and other diseases, think about it as like frogs. You need to kiss a lot of them until you find your prince or your princess at your choice, right? So we need to make sure that if there are a few clinical trials, there's sufficient people who are interested in participating to make the one that really will mature to treatment succeed. Now, so far we had one big clinical trial by Sanofi that Colombia was a site for those who carry the GBA gene. And unfortunately, it was stopped in February 2021 because they didn't reach the outcomes that they were hoping for. There is a cough drop over the counter in Europe and Canada that is called Ambroxol. In the lab, people found that it actually increases the activity of GBA, the gene that causes Parkinson's. So there are clinical trials in England and in Canada and hopefully soon in Israel to try to see whether this cough drop, this mucolytic agent, can help Parkinson's. The only reason it doesn't happen in the United States is because the medication is so cheap that no pharma will pick up the bill to pay for a clinical trial. But it is happening in other countries. And if it works, then it will work everywhere. In LRRK2, there are fancy mechanisms to try to work on LRRK2. So in LRRK2, it's a weird mutation. It actually makes the gene work more. In the Parkinson's, because the gene is overworking, not underworking. That's good news for patients in pharmaceuticals, because it's much easier to create inhibitors to block an enzyme than to make it work harder. So those enzymes are not, so similar drugs that block the enzyme were developed. One of the companies that is most advanced is Denali. And I don't know if you know of people with spinal muscular atrophy. That's a children's or babies' disease where they develop like a pediatric form of Lou Gehrig's disease, where the babies and the kids cannot move their muscles. A recent genetic treatment that was just discovered a couple of years ago, 3 years ago, 4 or 5 years ago, it depends if you count the clinical trials, completely changed their lives. Before that, they were doomed to not survive in different ages. And now with a genetic treatment that is inserted into the spinal fluid, these kids, they're not normal, but they maintain a much better life. And that has changed the world of genetic trials in neurology, because we saw that we can insert a genetic treatment, it's called ASO, antisense oligonucleotides, to the spinal fluids of people with neurological disease and change the outcome. So of course, we take this ASO mechanism and try it in multiple other diseases. In some, it may succeed. There is a disease called amyloidosis where it may succeed, and in some, it may fail. A couple of trials for this treatment in Huntington's disease just failed this year as well. We are trying it for Parkinson's, specifically targeting either the gene of LRRK2 or the gene of the alpha-synuclein that I told you that's the protein that is deposited in Parkinson's. So the hope is that if there's less of the protein, Parkinson's will progress slower. So for people who are highly motivated, clinical trials, you really need to know your genotype in order to participate. And that's a big game changer. for people who are motivated, but not as motivated for clinical trials. I think it's a lot to ask from someone to participate in a study where they don't know if they get a placebo or the control. Some of their interventions required spinal taps. It's not for everyone. But if people know that they're carriers but don't want to do a clinical trial like that, they can still contribute to the research of their own gene by donating blood samples, urine samples, and that's how we have a large grant from the Michael J. Fox Foundation that people donate blood and urine, and those are interested also spinal fluids, but it's not necessary. And we grow the blood in the lab and distributed it to multiple labs studying these genes. We sent shipments to Australia, to Greece, to France, to England, to Scotland, Canada, Australia, and multiple labs in the United States and Denmark. So a very collaborative effort where researchers around the world are trying to understand these two genes, LRRK2 and GBA, better, in the hope that if we understand the biology of why they cause Parkinson's, we'll be able to slow down the disease with people and maybe prevent it when the younger generation grows older. So I am very optimistic. If I didn't think that this would work, I would change careers, because that's what I do all day. I did it in New York, and now I'm doing it in Israel. And this research would never advance without motivated people with Parkinson's and family members that participate in it. So I'll take a break now to see if there's questions.
That certainly is a way to give, I must say. I mean, if you're, wondering how to give something of yourself, and especially, this is a good way to do it if it doesn't take up too much of your time and energy, and, to give a blood test, and those samples seem helpful the way you're talking about it.
Absolutely. We would not have discovered those genes if people did donate their blood before. We would not have, we wouldn't have known which proteins are bad for you in Parkinson's if people didn't participate in such studies.
Yeah.
Time for questions?
Yeah, I hope that's inspiring. Does anybody have any questions? Definitely got me to understand why it is important to do those clinical trials to help each other out. Here's a question. How do I find out if there are clinical trials that I'm eligible for? Would you call Evelyn? And
so we're calling Evelyn is a good start, because you can always email me and I can tell you. There is one website that I really like for people who like to look up online that is called clinicaltrials.gov. Any serious clinical trial is going to be registered in clinicaltrials.gov. If you're looking for infusion of stem cells in Mexico or China, you won't find it there. If you're looking for real studies of real drugs, clinicaltrials.gov is a way to go. Besides that, I strongly encourage people who are motivated. It's not for everyone. To look in the Michael J. Fox Foundation website and the Parkinson's Foundation websites. They do talk about recent studies. Michael J. Fox even funds a couple of the clinical trials. But if you have a GBA or LRRK2 mutation and you want to know what you can do with it, absolutely email Avi, and it'll probably reach me and I'll let you know. It depends on the geography of where you're located, and also about your Parkinson's. Your Parkinson's may be too mild for some studies. For example, in one of the studies at Cornell and Penn, they inject a virus infected with the healthy GBA gene to the spinal fluids. Now, this is something that the FDA allowed them to do only for people who are very advanced. I would be ambivalent about doing it, but if my, let's say, loved one, family member had significant cognitive changes and I felt like it's a real struggle, maybe I would encourage them to do that. But I'm not encouraging people to join a specific clinical trial. I'm just encouraging people who are interested to know about those and make a conscious decision.
Is there something that you could share with us that's on the horizon, that's hopeful, that you feel like you're getting close to?
Yeah. So
Any secrets you can share with us?
No, so I think that there are, I don't know which of the drugs would work. And the antisense oligonucleotides, those injections to the spinal fluids, are very exciting because they worked in another disease. So we know that they can do it if we get the right ones. I think the inhibitors of the LRRK2 gene are easier to take because they're orally taken. They're very interesting. A cough drop that is very benign also sounds promising to me. So I don't like, if you ask me, I'm promiscuous. I would kiss any frog around there because all of them are better than just more and more dopamine. And let's give more dopamine and see if it works, and if not, DBS. So I think the hope is in those clinical trials, and we hope that they will change. For people who don't carry genetic mutations or that we couldn't identify the genes, I think that the immune system activation is very exciting. I don't know if you followed the controversial decision of the FDA to grant some kind of a permission for Biogen for a drug for Alzheimer's, but that drug exactly works in the immune mechanism that I told you about, that it's activating the immune system against the amyloid plaques in Alzheimer's. Will it work? We don't know. The FDA made a controversial decision there because the trials didn't show benefit for patients, but it showed that their brain scans got better. But if the drug did get their brain scans better, there's no doubt. So these trials in Parkinson's are ongoing, and new ones are going to come in.
I think
So,
that's
yeah.
why also we team up Taryn with the doctors, because Taryn comes at it with another from another angle, and I think everybody can work together to do that. And I'm sure, Taryn, that you're dealing with the immune system in your way, so those techniques can all work together if everybody works on parallel courses.
And there's a question in the chat of what you advise the adult children of two siblings with Parkinson's question above, who don't have identified gene factor. What should they be on the lookout for? So again, it is possible that that the previous generation had Parkinson's from a non-genetic cause. But if there is a family with a lot of Parkinson's in it, I encourage getting genetic counseling, and someone needs to take a look and see the panel that was done, see whether anything needs to be added, and provide reassurance. Also, for people who are very concerned, I've done that before. I examine people to let them know whether I see anything alarming or not. And if I don't see anything alarming, it's also supposedly, hopefully reassuring. But if there's I think that there's lots of families that overestimate the genetic risk. And then people live with the fear that they'll have what their parent had. And it really isn't the case. Just to give you like to throw another number at you, in Sweden, when they took identical twins and one of them had Parkinson's, can you guess what was the chance of the identical twin to have Parkinson's? It was less than 15%, less than 1/5. So even someone that has exact same genetic makeup, some develop Parkinson's, some don't. It can go back to the nutrition. It can go back to other environmental risk factors. It can maybe go to epigenetic changes. We don't know, but the genes are not everything.
Dr. Alkalay, do you see this question from Jeff here?
So Jeff is asking, do CRISPR techniques hold promise with GBA, or are there too many unknowns presently to move forward with this in this direction? So all the CRISPR research that I've seen with GBA are focused on animal models, and I haven't seen any human trials reaching the phase where CRISPR is introduced. So there may be companies that are secretive, but I just don't know.
Well, I want to just thank you today, really, Dr. Alkalay. It was very informative, and I think everybody's very pleased to have had you give us your time to share this with, and it's to share this with us. And it's so good to know that you're there working hard for all of us. So I appreciate it very much. And Elizabeth Delaney, maybe just write your phone number and your contact information in the chat. And we have Evelyn's there. So if anybody wants to reach out to Evelyn to to get more involved in the genetic risk factors, can do that. So I want to thank everybody and just remind you that we have one more PWP MD lunch with our doctor next Tuesday at 12 o'clock, and we'll send you information on that. And it's great to see everybody. Thank you, Taryn. Thank you, Dr. Alkalay.
Liz, you wrote it to me, not to everyone. So if you don't mind, I'm sorry. Liz wrote me a private message with her phone number, but I do know it already. So I think she needs to share it with the entire group.
Okay, great. All right. So again, thank you. And please subscribe to our email list so you know what's happening if you're not already on it. And hopefully we'll see you next week. And Dr. Alkalay, enjoy your new position at that wonderful hospital. It's great that you're doing work for all of us. Thank you.
Thank you, everyone. Good night.
Good night. Good day.
Good day.